You have probably noticed it. One sock is tighter than the other. One shoe needs a little more effort to get on. One ankle, by the end of the day, looks noticeably different from the side you're comparing it to. You mentioned it at an appointment, and you were told it was probably just your veins, or just how your circulation had developed, or simply how your body is. And something about that answer never quite satisfied you. I want to tell you about a patient I'll call Barbara. She was 69 years old. For about 4 years, her right leg had been consistently larger than her left. Not dramatically, but noticeably. By afternoon, the difference was clear. She had worn compression stockings for 2 years. They helped a little. The asymmetry never went away. 2 doctors had looked at her legs and said the same thing. Venous insufficiency. Probably just how her circulation had developed. Something to manage, not to investigate. The 3rd doctor asked her one question that neither of the others had thought to ask. Has anything happened to this leg? Surgery, an injury, anything at all? Even years ago? Barbara had had a total knee replacement on the right side 6 years earlier. She had never mentioned it because she had never connected it. It had healed well. That was years before the swelling began. But the answer to Barbara's asymmetric swelling had been sitting in her surgical history the whole time. Today, I am going to show you 4 specific identifiable causes of one-sided leg swelling. 4 reasons why one leg consistently looks different from the other that most appointments never find, because most appointments never ask the right questions. A brief but important note before anything else. If your one-sided swelling appeared suddenly, over hours, not weeks, and that leg is also warm, red, or painful to touch, please seek medical attention today. Those symptoms together can indicate a deep vein thrombosis that requires prompt evaluation. What I am covering today is the leg that has been gradually and consistently larger than the other for months or years without sharp pain, warmth, or redness. That pattern is rarely dangerous, but it is almost never properly explained because just how your body is not a diagnosis. The end of a conversation that should have continued. One leg consistently larger than the other is a specific, measurable, observable finding, and it has specific causes. Let me take you through 4 of them. The first cause is the most common hidden driver of asymmetric leg swelling in women over 60, and the most frequently missed because it requires connecting something that happened years ago to something that is happening now. Your lymphatic system, the drainage network we covered in an earlier video, is a web of tiny vessels running through every layer of tissue in your body. Unlike your blood circulation, which has the heart as its dedicated pump, the lymphatic system depends on muscle contractions, breathing, and movement to push fluid upward against gravity. What most people don't know is that surgical procedures can disrupt lymphatic vessels. Not catastrophically, not visibly, but in a way that permanently alters how fluid drains from the area of surgery. A knee replacement, a hip replacement, a hernia repair, pelvic surgery, any procedure involving significant dissection near the groin, thigh, knee, or pelvis can damage or redirect the lymphatic vessels that drain the leg. In many cases, the disruption is subtle enough that the body partially compensates for a while. The remaining lymphatic vessels work harder to cover for the ones that were disrupted. But over the following years, as those remaining vessels age, and as the lymphatic system's natural capacity declines after 60, as we've discussed in this series, the compensation begins to fail. The result is a leg that drains measurably worse than the one that wasn't operated on. Barbara's knee replacement was 6 years before her swelling became noticeable. That delay is exactly what the clinical literature describes. The swelling is not immediate. It appears as the compensating system ages out. The question to ask yourself, has there been any surgery, infection, or significant injury near the groin, abdomen, thigh, or knee on the side that swells more, even years ago? That history is clinically relevant, and it should be part of every conversation about asymmetric leg swelling. The second cause is the one that most genuinely surprises doctors. The one that, when it is finally found, often comes as a revelation not just to patients, but to the clinicians who have been managing their symptoms for years without a satisfying explanation. And it is relevant almost exclusively to one specific leg. It is called May-Thurner syndrome. And if your left leg is consistently more swollen than your right, this is something you need to know about. Here is the anatomy. Your left iliac vein, the large vessel that carries blood from your left leg back toward the heart, runs a very specific path through your pelvis. On that path, it passes directly behind the right iliac artery. And in a significant proportion of people, that artery compresses the vein from above. Not completely, not enough to stop blood flow entirely, but enough to restrict venous drainage, enough to create a chronic, one-sided backup that results in the left leg retaining more fluid than the right. Published research has confirmed that the anatomical variant underlying May-Thurner is present in an estimated 22 to 24% of the general population, meaning roughly 1 in 4 people has this compression point in their pelvis right now without knowing it. Among women specifically, the condition is recognized at a rate 2 to 3 times higher than in men. And among patients who develop deep vein thrombosis, specifically in the left leg, studies have found May-Thurner syndrome as a contributing factor in 18 to 49% of cases. Most patients with May-Thurner syndrome are told they have venous insufficiency, or lymphedema, or poor circulation. All of those things may be true, but they are consequences of the compression, not the underlying cause. The critical point is that May-Thurner syndrome cannot be identified through a routine clinical examination. It cannot be reliably found on a standard leg ultrasound. It requires specific vascular imaging, CT venography or contrast venography, to diagnose. Most patients are never referred for that imaging because the possibility is never considered. A 2026 case report published in the journal Sonography describes precisely this pattern. Persistent multiple clinical evaluations, normal standard ultrasound, and May-Thurner syndrome found only when CT venography was specifically requested. If your left leg has consistently been more swollen than your right, and you have never had a satisfying explanation, May-Thurner syndrome should be part of that conversation. The third cause is one that affects a significant number of women. Researchers estimate somewhere between 6 and 11% of the female population. and has one of the longest average diagnosis delays of any condition in women's health. Many women living with it right now have been told the problem is their weight. It isn't. It is called lipedema. And the first thing I want to say is this: it is not obesity. It is not excess weight that can be controlled through diet or exercise. It is a distinct medical condition involving a specific type of abnormal adipose tissue that accumulates below the waist. In the thighs, the hips, and the calves, and that does not respond to caloric restriction the way ordinary body fat does. Research published in Obesity Reviews in 2025 estimates that lipedema affects between 6 and 11% of women in the general population. A 2026 PMC review places that figure higher, at 11 to 15%. Despite that prevalence, 2025 clinical review found that diagnosis may be delayed by up to 10 years because lipedema is routinely misidentified as obesity, lymphedema, or venous disease. In that time, most women are told to lose weight, exercise more, or eat less, advice that does nothing to address the condition and that many women find both ineffective and deeply discouraging. Here is the most important diagnostic clue, and it is one you can observe yourself right now. In lipedema, the feet and ankles are spared. The fat accumulation stops at the ankle. If you look at your legs and the ankles appear relatively normal, while the calves and thighs carry disproportionate volume, that pattern is a specific and recognized feature of lipedema that distinguishes it from lymphedema, where the feet and ankles are typically among the first areas to swell. The asymmetry in one-sided swelling comes from the fact that lipedema, while generally affecting both legs, is not always equal on both sides. One leg may carry noticeably more tissue than the other. Combined with the tissue's characteristic tenderness, lipedema tissue bruises easily, feels disproportionately painful when pressed, and causes discomfort that ordinary fat simply does not. These features together paint a picture that is distinct from simple weight gain or venous disease, and it is worth noting that lipedema worsens after hormonal changes. Research published in Frontiers in Cell and Developmental Biology in 2025 confirmed that fluid retention and pain specifically worsen post-menopause due to hormonal shifts, meaning many women over 60 who have had condition for decades find it becomes noticeably more pronounced in their later years at exactly the age when it is most likely to be attributed to aging. If you have disproportionate lower body volume that has not responded to diet or exercise, ankles that look relatively slim compared to your calves and thighs, and tissue that is tender or bruises easily, please look up lipedema and bring that word specifically to your next appointment. And here is the one that may be touching the most people watching right now, because the fourth cause is the most common cause of one-sided leg swelling of all. And the way most doctors manage it when only one leg is affected is almost always the wrong approach, not slightly off. Specifically, measurably wrong in a way that can be corrected in a single appointment. Your leg veins contain one-way valves that prevent blood from falling backward under gravity when you're upright. When you walk, your calf muscles squeeze the veins and push blood upward. The valves close behind each push, preventing it from falling back. That is how blood returns from your feet to your heart. When those valves fail, they no longer close properly. Blood refluxes downward between steps, pools in the lower leg. The capillaries beneath the skin come under increased back pressure, and fluid is pushed out into the surrounding tissue. By the end of the day, the leg is swollen, heavy, and aching. And by the following morning, after hours of lying flat with gravity neutralized, it has partially drained. That morning to evening pattern is the classic signature of venous valve failure, and you will recognize it if it is your cause. In most people, valve failure develops gradually in both legs, but it almost always begins worse in one leg first. The anatomy of the two legs is rarely identical. One side may have experienced more pressure over decades, from a past injury that strained the vein, from standing patterns that loaded one leg more, from a pregnancy that applied more pressure to one side. Whatever the origin, when one leg's valves deteriorate meaningfully ahead of the other, the result is chronic, asymmetric swelling that looks like general venous disease, but is unequal in degree. Other signs that point specifically to venous valve failure as your cause. Visible varicose veins or spider veins on the more swollen side. A feeling of heaviness or aching in that leg that builds predictably through the afternoon. Skin changes over time, a brownish discoloration around the ankle or lower calf on the affected side, caused by red blood cells leaking through chronically overpressured capillary walls. These are venous signs. They point to valve failure rather than lymphatic disruption or the structural compression of May-Thurner. Now, here is the treatment error that affects a significant number of people with one-sided venous valve failure. Compression stockings are the standard treatment, and they are effective when used correctly. But compression stockings come in different classes of pressure. Class 1, Class 2, Class 3. The appropriate class is determined by the degree of valve insufficiency in the specific leg being treated. When one leg has significantly worse valve failure than the other, which is precisely the situation in asymmetric swelling. The more affected leg typically requires a higher compression class than the less affected one. But most people are prescribed identical stockings for both legs based on the most affected leg's measurements and then applied symmetrically. That means the better leg may be in stockings that are unnecessarily firm. And more importantly, neither stocking is optimally calibrated to the individual degree of insufficiency in each limb. If you have been wearing bilateral compression stockings for a leg that swells more on one side, ask your vascular specialist or a certified lymphedema therapist specifically whether each leg has been individually assessed for compression class. That single question in a single follow-up appointment, it may change the quality of your treatment. Here is what I want you to bring to your next appointment. And one thing you can do at home right now before you go. First, describe the pattern precisely. Which leg is larger? When the difference appears. How long it has been this way? Whether it followed any identifiable event. The more specific your description, the more useful it is as a diagnostic tool. Second, share your complete surgical and injury history on the affected side, including anything near the pelvis, abdomen, groin, thigh, or knee, even if it was years ago and seems unrelated. Post-surgical lymphatic disruption is a recognized cause that most doctors don't consider unless the patient raises it. Third, if your left leg is consistently more swollen than your right, asks specifically whether May-Thurner syndrome could be contributing and whether CT venography would be appropriate to assess the left iliac vein. Standard ultrasound frequently misses this. Fourth, look at your ankles. If they appear relatively slim compared to the volume in your calves and thighs, and if the tissue is tender or bruises easily, bring the word lipedema to your doctor by name. And the thing you can do at home right now, there is a simple self-check used in clinical lymphology called the Stemmer sign. It takes about 5 seconds. Try to gently pinch and lift a small fold of skin at the base of your second toe, the one next to the big toe. If you can easily lift a soft fold of skin, that is a negative result and suggests lymphedema is less likely to be the primary cause. If the skin feels thick, firm, or difficult to fold and lift, that is what clinicians call a positive Stemmer sign, and it is a recognized indicator that lymphatic involvement may be present in that limb. It is not a definitive test, but it is a piece of information that is clinically meaningful, and it takes you 5 seconds to check right now and share with your doctor. Let me close with something I want to say directly. Because the answer most of these women received, including Barbara, was not an answer. It was a door closing on a question that deserved to stay open. Just how your body is not a diagnosis. It is the absence of one. One leg consistently larger than the other is specific, observable, and measurable. It has causes. Most of those causes are identifiable. Several of them: post-surgical lymphatic disruption, May-Thurner syndrome, and lipedema go unidentified for years, specifically because the right question was never asked, or the right imaging was never ordered, or the right name was never mentioned in the room. Barbara's swelling did not disappear, but once the post-surgical lymphatic disruption was recognized, she finally had a correct diagnosis, a correctly identified system to support, and targeted drainage techniques for the right leg rather than both legs identically. The difference she noticed within the first 3 weeks was not dramatic, but it was real. And for the first time in 4 years, she had a reason for what was happening. That alone, she said, changed something. You deserve the same. Not a dismissal, an answer. Drop a comment below and tell me, is it your left leg or your right that tends to swell more? I read every single response, and the pattern across this community genuinely helps me understand what to cover next. If someone you know has been living with this and accepted just how your body is as the final word, please share this video with them. There is very likely more to know before you go. This is the 6th video in this series. We have covered the nerve signal behind 3 a.m. cramps, what blood pressure medications may be doing to your leg nerves, the lymphatic system failing every afternoon, what restless legs are warning you about, the vagus nerve, and the stress-magnesium cycle. Today, 4 reasons why one leg swells more than the other that most appointments never reach. Every one of those conditions sits in the legs. Every one of those conditions has a cause that runs deeper than the leg itself. And that deeper cause, the single thread connecting nerve health, lymphatic function, inflammation, and the stress response across everything we have covered, has a significant and underappreciated root in the gut. Next week, I am going to show you what the TwoSound 2025 research says about the gut microbiome and leg health after 60. What changes in your gut bacteria with age, what your legs feel as a consequence, what 3 specifically changes published studies suggest may begin to shift that system in your favor. Subscribe, because next week's video is the one this entire series has been building toward. And it may be the most practically useful one yet.